It is really a privilege being here for this talk in this ancient university. I am well aware of the connections that have existed in the past between...
vice versa,
Yes, and then why not? I definitely think we should re-establish this connection to increase our knowledge and to help our patients. And I will try to show how this cooperation, this international, particularly, but not only, European cooperation could actually improve how we treat our patients. And I also will try to answer your question. That is a question that many patients and many physicians and regulatory agency ask if this is cancer. I will try to show you that this is indeed a plasma cell cancer that kills patients not because the biology of cancer, but because this cancer produces a toxic product, a toxic molecule. And to start here, I think we could think of AL amyloidosis, of amyloidosis altogether, of all types of amyloidosis, as a final common pathway for protein deposition in tissues. Many unrelated proteins produced by our body, almost 40 types of protein, can misfold, interact with different components of the interstitial environment and end up depositing in tissue in the regular form of amyloid fibrils. And this process causes organ dysfunction and eventually death if it is not arrested by effective treatment. But why is it so that these proteins aggregate and form amyloid? This can be different causes. There can be proteins like serum amyloid A, that is an acute phase reactant, that have an intrinsic propensity to form amyloid, but they need to be at an elevated concentration for a sufficient amount of time. This happens with SAA in patients with chronic inflammation. There are other proteins whose concentration is increased by reduced clearance. This is the case of beta-2 microglobulin in dialysis-related amyloidosis. In other proteins, the amyloidogenic propensity, as to say, is increased by the introduction of mutations that make this protein more likely to form amyloid in tissues. And there are proteins that, given enough time, will develop amyloid deposits. This is, again, transthyretin that can give rise in elderly men to what was called senile systemic amyloidosis, which is becoming a much more frequent diagnosis nowadays. If we look at our practice of these 40 types of amyloidosis, the types of systemic amyloidosis that we see at a referral center can be synthesized in this slide. There are 6 main types of systemic amyloidosis that we can encounter in our practice. 3/4 of patients will have AL amyloidosis that is caused by monoclonal light chains. There are some patients with hereditary amyloidosis that can be caused by transthyretin or ApoA1 amyloidosis. There is an increasing number of patients with senile systemic amyloidosis caused by wild-type transthyretin, a few patients with amyloidosis reactive to chronic inflammation, and recently it has been discovered this form of renal amyloidosis that is caused by leukocyte chemotactic factor 2. This amyloidosis gives rise to kidney and liver involvement in patients of Southern American, they say, Latin origin. However, it is important also in Europe because some cases have been described in patients from North African ancestry that, as you know very well, are now coming in the European Union. If we look at organ involvement, there is a substantial overlap of clinical presentation, of organ involvement between these 6 common types of amyloidosis, so that the clinic of the disease, the clinical presentation, does not help us to discriminate between one type of amyloidosis and another. Heart involvement can be present in AL amyloidosis, in TTR amyloidosis, kidney involvement in AL, and AA amyloidosis. However, the association of definite heart and kidney involvement strongly points to AL type amyloidosis, and this can be a clinical hint, of course. First of all, I would like to talk about diagnosis of this disease, and I will particularly emphasize the need of early diagnosis, because as I think we all agree and know, amyloidosis often goes undiagnosed, and when it is diagnosed, it is unfortunately often diagnosed late. To diagnose amyloidosis, we need a tissue biopsy. There is a site that is readily accessible and can be biopsied with a minimal invasive procedure for our patients. That is the abdominal fat. This is an abdominal fat aspirate stained with Congo red and observed under polarized light at our center. The sensitivity of this procedure is approximately 80%. So it is not 100% sensitivity, and if you have clinical suspicion but the abdominal fat aspirate is negative, you need to go further. A possible following step to biopsy is the minor salivary gland biopsy. This is also minimally invasive, and the sensitivity is almost 60% in patients who have a negative fat aspirate. But again, sometimes you will need the biopsy of the organ involved. This should be done with caution, particularly for liver biopsy that prefers the transjugular approach due to a possible risk of bleeding. Going in sequence may require time. So if you feel the patient has a worsening disease and needs treatment in a hurry, you can just jump from abdominal fat to the organ biopsy in order to spare time. However,
skin biopsy could be falsely negative.
Yes.
In other words, you have amyloidosis.
Yes.
In particular place, but we know positive results.
Yeah. So you have to be aggressive in looking for the disease.
Multi-puncture or place where if something.
There are places where it is likely that particularly AL amyloidosis is found. That is the fat, the rectal biopsy, the bone marrow biopsy. So if the patient has proof of a clone, you can also go for the bone marrow and find deposits there. But the approach should be driven by your clinical feeling. And if you feel that there is involvement of an organ, and if you feel you are losing precious time for your patient, you should definitely go to the involved organ. Also because once you get the biopsy, the diagnosis is far from being established, because you don't only need to demonstrate that the patient has amyloid, but you need to demonstrate that the patient has a particular type of amyloid, because treatment is enormously different between types of amyloidosis. So you can do terrible mistakes, such as transplanting the wrong organ if you do not have a correct typing. So tissue typing is next step and is always mandatory. Unfortunately, immunohistochemistry under light microscopy is it is not specific for AL amyloidosis. There is a background effect, and also the epitopes change so that the commercial antibody usually do not work. It is reliable for AA type amyloidosis, immunohistochemistry, but it is usually not reliable for AL amyloidosis. In Germany, the group of Heidelberg and of Hamburg now use this technique, but they use this with specific custom-made non-commercial antibodies that increase the specificity. In Italy, we use immunoelectron microscopy with commercial antibodies. The advantage of this technique is that this technique can co-localize the antibody that is marked with the gold particle with the amyloid fibril, so that you increase specificity. And indeed, the specificity in our hands is 100%. And this is, I'm sorry that the picture is small, but this is a bulk of amyloid fibrils that is specifically recognized by an anti-lambda antibody. More recently, the diagnosis has moved forward using mass spectrometry-based proteomics. That can be done on a regular slide after laser capture microdissection or in the whole tissue. This technique is not antibody dependent, so it is now allowing to discover new types of amyloidosis that you don't need to know before with what antibody to find. Of course, if you find a protein that can be mutated and can be part of the clinical picture of an hereditary amyloidosis, you have to confirm this with DNA analysis, particularly if you find transthyretin, to discriminate between wild type, senile disease, and hereditary disease. And in this respect, the availability of scintigraphy with bone tracers has elegantly helped our ability to discriminate between these two types of amyloidosis. These bone tracers, DPD is used in Europe and PYP, pyrophosphate, in the US, are specifically uptaken by the heart of patients with non-AL, particularly ATTR type of amyloidosis. These two patients from our center had similar echocardiographic pattern. The one on the right here had AL amyloidosis, and the one here had ATTR amyloidosis. These are extreme cases. There is a continuum of clinical and scintigraphic picture between this and these. So if you have both a monoclonal component and uptake, you should in any case go for heart biopsy or tissue biopsy. Once you have demonstrated, the topic here in hematology is AL type amyloidosis, so when you have demonstrated that your amyloid deposits is made of light chain, then you will need to look for the clone. And the clone is usually small and difficult to detect. The median bone marrow plasma cell infiltrate in a series of more than 1,000 patients diagnosed at our center is 10%, and 20% of patients will have less than 5% plasma cells in their bone marrow. This is a synthesis of the experience of 3 referral centers with current techniques to find the clone, and you see that acceptable sensitivity is only obtained with the combination of immunofixation of both serum and urine and the free light chain test. So if you suspect amyloidosis, you have to test both serum and urine, and you have also with immunofixation, and you have also to quantify the circulating free light chain. Now in Europe, there are 2 marketed assays for the free light chains. One is produced by the binding site, and is called the free light assay, and one by Siemens, and is called then latex FLC assay. Both perform similarly in the diagnosis, but the value that they give are markedly different. They are not interchangeable. So the response and prognostic criteria that have been designed with the free light test cannot be applied to the latex FLC test. So you should also check with which test your patients are followed.
So despite the fact that the number of precursors are small,
yeah,
it's clonal disease.
Yes.
So in this terms, it's malignant disease.
Definitely.
It's no plastic disease.
Yes.
But as you said,
it's a small.
This clone is killing the patient, the products.
Yes.
That is very giving tremendous impact on
yes, definitely. And this is summarized. This is summarized here. You have a clone, usually small, that produces a light chain, a monoclonal light chain, that can deposit in tissues and also exert a direct proteotoxicity on the organs. This can affect virtually all organs in our body, with the exception of the brain, but all other organs can be affected by AL amyloidosis. The heart is involved in 3/4 of patients and the kidney in 2/3 of patients. And organ tropism is partly explained by the usage of germline gene. So germline lambda 1 as a tropism for the heart, and lambda 6 for the kidney, as shown by several groups. This is the survival curve of the patients diagnosed in the last 10 years in Pavia. This is only the patients who were diagnosed for the first time at our center. This is not patients referred to us from other physicians. So these are homogeneously diagnosed and treated. And they have been treated in recent years. Despite this, you see that we are losing 30% of patients in the first year after diagnosis. And that median survival, even in this modern series, is only 40 months. It is the heart that drives the prognosis of these patients. If I divide the overall population, this red curve, in two groups, one, the black one, with cardiac involvement, and the green patients without cardiac involvement, you see that it is the heart that gives the shape to the curve. All early deaths are cardiac deaths. And the pace of progression of patients without heart involvement is very slow. These patients, with rare exceptions, need to develop heart involvement first and then can die. So the heart is terribly important in these patients, and it is...
It's main target.
Yes.
Main target. Why heart?
There are interactions with specific myocardial proteins that I will show later. This is an interesting study that was made by patients. Isabel Luzada is the first author and is actually a patient who made this survey amongst patients with a questionnaire. And she found that almost 40% of patients had to wait more than 1 year after the onset of symptoms of the disease, after they became symptomatic for heart failure or nephrotic syndrome, before they get the diagnosis. And after 3 years, still 10% of patients did not have a diagnosis. This is years of symptoms. But when the disease becomes symptomatic, this is the heart, the prognosis is often irreversibly done. You see that here the green curve is patients who have heart involvement that is not detectable by echo or by symptoms, and this is symptomatic patients. And of course the prognosis is much worse, and almost all the early deaths occur in symptomatic patients. We have a marker of heart involvement that is NT-proBNP. The circulating marker has a 100% diagnostic sensitivity for cardiac involvement in AL amyloidosis. So you will have no one patient with cardiac AL amyloidosis and normal NT-proBNP. You will have some patients here who have an elevated NT-proBNP without signs of heart involvement. And the London group showed very elegantly again that these patients are deemed to develop heart involvement, symptomatic heart involvement in the following months, and to die of heart involvement if not effectively treated. So there are patients with asymptomatic heart involvement that we can detect. And before the symptoms developed. So,
by the way, congratulations for circulation publication.
Yeah.
Palladini.
Yeah.
Impact factor, I think 25?
Approximately, yes. I was very young, and this explains my career. I was 30, yeah. And I'm no longer so good. And the same holds true for nephrotic syndrome. So there are patients with asymptomatic renal involvement who only have albuminuria, who only have proteinuria. And if you diagnose amyloidosis at that stage, because before the patient has leg swelling due to nephrotic syndrome, then the rate to progression to dialysis, this is not death, this is progression to dialysis, is much lower. So an asymptomatic stage exists also for renal involvement. So the question is, can we screen for AL amyloidosis? Can we screen for a rare disease? My personal history is strange, so despite working as a hematologist, I became professor of clinical chemistry. So what I do in my first lessons to a medical student is explaining that you cannot screen for a rare disease due to the Bayes theorem. The pre-test probability is so low that even very good tests will produce too many false positives. However, in this particular case of AL amyloidosis, we can identify a population at risk with at relatively high risk of developing amyloidosis. We know that 9 to 12% of patients with MGAS who progress will develop AL amyloidosis. So AL amyloidosis is 10% of progressions from MGAS. And you hematologists are following, according to the Mayo Clinic criteria, those MGAS patients who have an abnormal free light chain ratio. But looking at a population of patients with AL amyloidosis, 85% of patients with AL amyloidosis have an abnormal free light chain ratio. And almost all the patients with AL amyloidosis at presentation have either an elevated NT-proBNP or albuminuria. So what we propose, and we finally eventually managed to have this introduced in the American Society of Hematology guidelines, is to screen for AL amyloidosis in MGAS patients with an abnormal free light chain ratio, measuring NT-proBNP and albuminuria. These patients are followed by hematologists, and what you need is just adding these two tests in their follow-up. Next step, when you have made a diagnosis as early as possible, possibly in a pre-symptomatic stage, you need to define prognosis in order to find the best treatment for these patients. And we have already understood that the severity of cardiac involvement depends, actually is the major driver of prognosis. And heart dysfunction is best assessed with biomarkers. We use NT-proBNP and troponin. There is this staging system that was proposed by the Mayo Clinic, and you see here its application in the Italian patient population I presented you before. We have stage 1 patients with normal biomarkers, and the stage 3 patients with both biomarkers above the cutoff. And you see that all early deaths segregate in these unfortunate patients that now we can detect in the afternoon of the first evaluation in our office.
The early death is connected to cardiac arrest?
It's 1/4 is cardiac arrest, 3/4 is just progressive heart failure. Okay. But we can go further. We can actually divide this red curve that we call stage 3 into 2 stages, stage 3A here and stage 3B. These are stage 3 patients with very high NT-proBNP, greater than 8,500. This was a European study of our center, the London center, and the Greek patients. And you see here that almost 80% of stage 3B patients will die in the first year after diagnosis. And there is very little we can do for these patients.
Can you stay one day longer? Because tomorrow my cardiologist colleague would like to hear your lecture. Arthur, you should invite here cardiologists.
I invited.
But they are not interested.
They are not so happy to come.
Anyway, have we ever had a suggestion from cardiologist side that they have patients probably heart failure due to amyloidosis and they transfer to us? Never happened. Do you remember? I don't remember. You had one patient. But anyway, you see my point.
Yeah.
I'm joking, but
You are
really,
right.
Mostly cardiology
Yes.
problem.
This is, sorry.
My personal experience was that once
It's clinical chemistry.
when we screened all patients from cardiology, we found two unrecognized monoclonal gammopathies. So that was
Yeah.
probably the main
So,
reason
yeah.
that found
Yes,
it.
definitely. This is one thing that should put everybody of us together, clinical chemistry, hematology, and cardiologist and nephrologist to start with. And this is centers like our centers exist because they stemmed from cooperations until they could stand alone. But why is it that the heart is so important, as you asked me before? It was our patients who taught us the pathogenesis of this disease. So this began with the clinics back, what the Americans say now, from the bedside back to the bench in this disease. And this started with our paper on NT-proBNP in 2003. At that time, I was still doing charts for myself, and we did measure NT-proBNP on frozen sera. And just to try, I not only measured this on the baseline sample, but of a couple of patients in whom I have a long history, I tried to draw this chart, and I did it in 4 patients, and this is the one who really struck me. This was a lady who presented with severe heart failure, a monoclonal component, and an interventricular septum thickness of 14 millimeters. She was diagnosed with AL amyloidosis. She was treated. Her NT-proBNP decreased. Her heart failure improved. And very strikingly, the concentration of the cardiac marker was parallel to that of the monoclonal component. And then she remained stable for a while. Then she progressed and unfortunately died. And there was still this parallel movements, changes of the monoclonal component, the clinical picture, and the cardiac biomarker that was not accompanied by changes in the amount of amyloid deposited in the heart. So I remember I ran to Professor Merlini, who was at that time my mentor, who still is my mentor, and I said to him, this is toxic. This is a poison in their blood. It is the monoclonal component and not the deposits. And yes.
Comment that higher level of NT-proBNP there is very useful universal marker of useful for amyloidosis, but high levels are a little bit complex because not only arises not only because of heart.
Yes. Renal failure can be, yes. Atrial fibrillation. It is not specific.
Yes.
Definitely, if it is not, even kidney failure, lung disease, for example, and lung infection. These measurements should be done in a steady state, and you should take into account renal failure. But
more complex, more universal.
yes. Yes, yes, but as I will show you, there is a special link between the light chain and NT-proBNP that makes it special, though not specific for AL amyloidosis. And Professor Merlini told me that I had to study because 2 years earlier there was that publication from the cardiologist, the experimental cardiologist of Harvard University. This was a model of isolated mouse heart. This was published in 2001. It is history now. But upon infusion in this model of light chains isolated from the urine of patients with cardiac AL amyloidosis, in a matter of minutes, before amyloid deposits could form in the heart, there was an increase of end diastolic pressure. So there was a restrictive cardiomyopathy in this isolated heart in a matter of minutes. It required years to us to find animal models to study this hypothesis of light chain toxicity. And finally, we came out with this model of C. elegans. C. elegans is a worm, and it has a pulsating pharynx that actually beats regularly like the vertebrate's heart. If you give these worms light chains from patients with cardiac AL amyloidosis, the pharyngeal beats, the pharyngeal frequency decrease. And it does not happen with renal light chains or with light chains from patients with multiple myeloma. Again, in collaboration with the cardiologists of the Harvard group, we injected light chains in the heart of the zebrafish. The zebrafish who received light chains from patients with cardiac involvement had a much shorter lifespan and had a reduction of the cardiac outputs. This in the absence of amyloid deposits. So we concluded that light chains were cardiotoxic, and studying the cellular modifications of this model, we found that the toxicity was dependent on this mediator, that is p38 MAP kinase, that produced cell deaths and oxidative stress in the cells. But this same pathway is used in cardiomyocytes to increase the synthesis of BNP. This is why BNP is so important in AL-type amyloidosis, because the light chains actually act on the synthesis, directly increase the synthesis, and we can use of BNP, and we can use the heart of our patients as a sensor of the toxicity of light chains. There are specific interactions of the amyloidogenic light chains from cardiac patients with protein from the mitochondria of the cardiomyocytes. This was also demonstrated at our lab, and you can see also how the hearts of patients with AL amyloidosis have a mitochondrial damage. So there is a specific interaction between cardiac mitochondria and light chains that depletes the cardiomyocytes of energy. And indeed, if you think of it, the part of the muscle cycle that requires energy is diastole. It is relaxation. It is not systole. This is why we believe that AL amyloidosis is a chemical restrictive cardiomyopathy and not a mechanical, or at least not only a mechanical restrictive cardiomyopathy. And what about the clone? Is this plasma cell neoplasm? Is this plasma cell cancer only driven in its prognosis by cardiac factors? Well, no, the clone has a meaning in the long term. Once the period of early deaths and early drops in the survival curve has occurred. So the Mayo Clinic group improved the staging system by including in the staging system as a third factor the bulk of circulating free light chains. They also showed that patients who had greater than 10% plasma cells had a worse outcome in the long term, because they are more likely to relapse than patients who have only less than 10% plasma cell infiltrate. But in my view, what is even more important, because what we have to do is to have our patients survive the first months, definitely now. But what is particularly important is what the German group from Heidelberg showed. They showed that the translocation 1114, which is very frequent in patients with AL amyloidosis, it is found in approximately 50% of patients, is associated with lower benefit from bortezomib and greater benefit from melphalan, while the gain of 1q21 is associated with poorer outcome with oral melphalan. So we can use the iFish to personalize the treatment approach to our patients. In a way, it is simpler than in multiple myeloma. And I believe in the future, these will be the most important information that we have from our patient's clone. And what about the kidney? That is the second most important organ. Well, nowadays, at least in Europe, where the dialysis is affordable, in Western Europe, where dialysis is affordable everywhere, in the European Union, we do not have deaths for renal failure unless the patient decides not to undergo dialysis. However, renal involvement actually prevents patients from assessing aggressive treatment and most effective treatments, and also is a limitation for their quality of life. So we came out with this staging system for renal involvement. Here you see the proportion of patients requiring dialysis, not deaths. And you can stratify patients according to proteinuria, with a cutoff at 5 grams in 24 hours, and glomerular filtration rate with a cutoff of 50 mils per min. If a patient is diagnosed before he or she reaches these cutoffs, then renal damage is reversible. If the patient is diagnosed late, when both the markers are unfavorable, the risk of dialysis is 60% at 2 years. And these findings in the Italian series were validated in the German patient populations with almost equal and almost identical outcome. So we can now stage our patients. We can have the feeling of the severity of this disease and how can we treat them. Of course, we have to go back to the pathogenetic cascade, and the first target that we have is targeting the clone, borrowing treatment strategies from multiple myeloma. But there are other steps now, proteotoxicity and amyloid deposits, that we could target possibly in the near future with novel drugs. And very importantly, also these patients do not only have hematologic malignancy, but they have a multi-organ involvement and they need supportive therapy, very close and strict and attentive supportive therapy in order to make them able to get chemotherapy. Otherwise, they will die during chemotherapy. This is the landscape in the last 10 years of treatment types at our center. You see, in the first 4 years after we introduced the melphalan dexamethasone in 2004, many of our patients were treated with melphalan dexamethasone. Then it came bortezomib, and now bortezomib accounts for almost 90%, 85% of upfront treatment. And you see that we in Italy transplant upfront only a few patients, but we transplant many patients second line after exposure to not stem cell jeopardizing treatments. So we do more transplant as rescue compared to Americans and German colleagues. We have an approach more similar to French and British groups. But we should keep in mind this very elegant study published 4 years ago by Angela Dispensieri. She compared the outcome of patients with AL amyloidosis and multiple myeloma who were transplanted. And you see that at the beginning, the patients with AL amyloidosis are at higher risk of death. But in the long term, patients with AL amyloidosis have a better prognosis than those with multiple myeloma. This is when the clonal characteristic became important in driving the prognosis. And it is even more striking, this difference, for patients who eventually obtain a complete response after transplant. The patients with AL amyloidosis tend not to relapse, so they can be followed for years once a hematologic response has been established. So it is very difficult to cure these patients, to treat these patients at the beginning. You need to be aggressive in controls and very soft in treatment, opposite to multiple myeloma. Then you can be intensive in relapse.
So you could eradicate the small clone of plasmacyte producing light chains.
Yeah.
And it's less danger that you will be relapsing after some time than multiple myeloma.
Yes, it could not even not relapse.
Could not do that.
Yes, yes.
Thanks to eradication of the clone.
Even yes, it is easier to eradicate, and it can, even if you do not eradicate
because
it,
the clone is smaller?
because the clone is smaller and probably less aggressive.
Less aggressive. Or more sensitive.
Or more sensitive. Or more sensitive. Yes. Yes. But even if you do not reach a complete response, still it can be stable for a long time.
If the organ changes are not irreversible.
If organ changes, that's the key. That's the key. To understand what should be the target of treatment in AL amyloidosis, we set up a huge international group that collected more than 1,000 patients with AL amyloidosis to establish the new response criteria. These are the criteria for response that we use now. Hematologic response is divided in complete response that requires negative serum and urine immunofixation and normal free light chain ratio. We have a very good partial response that is defined differently from multiple myeloma. It is an absolute concentration of DFLC, difference between involved and uninvolved free light chains. That should be less than 40. This is because this is not a marker of the clone, but it is the actual pathogenic molecule that we are measuring. So if we manage to keep this concentration low, then we will have a long survival. And then cardiac and renal response are assessed with cardiac biomarkers. You see that each step, each category of hematologic response is associated with better survival. So it is not just consensus. This was validated based on survival outcome. The lower the concentration of the toxic protein, the better. But then we can ask the heart when we have reduced the light chains enough. So if you observe an NT-proBNP decrease by at least 30% during treatment, then the prognosis of your patients will improve. If NT-proBNP increases despite treatment, then patients will have a very poor outcome. And again, we can use a biochemical marker of the disease also for renal response that is defined as a decrease in proteinuria greater than 30%. Those patients who achieve this goal will have a less probable progression to end-stage renal failure and dialysis than other patients. So this is important because this is validated. Again, this is not consensus. This can be used as surrogate markers in the design of clinical trials. We do not need to see progression. We do not need to see death. We just can look for response. Very recently, two collaborators of mine in my lab have applied the study of minimal residual disease by flow cytometry to patients with AL amyloidosis. We have studied 21 patients so far, and all of these patients were in complete response with current criteria, and 9 of them still had minimal residual disease. And we found an association between persistence of minimal residual disease in what was otherwise believed to be complete response and lack of organ response. This is important in view of the definition of possibly irreversible organ damage that can be maintained by possibly undetectable amounts of light chains, and also in the design of newer strategies in order to improve the concentration of, to improve the quality of response, to increase the likelihood that the organ improves. Should we target the deposits or should we continue targeting the clone if the patient has minimal residual disease? I hope we will be able to update these results in Madrid at the meeting of the European Hematology Association. Coming to treatment, we have just borrowed from you hematologists the treatment regimens for AL amyloidosis. This is a summary of the three largest studies that we have in the field with stem cell transplant in AL amyloidosis. You see that a hematologic response is obtained in more than 70% of patients, that we see complete response in 1/3 of transplanted patients, and that overall the median survival of transplanted patients is more than 7 years. Importantly, if we look at patients who obtain complete response, there are no deaths after 14 years. So it is possible that these patients can be considered operationally cured. The rate of complete response, as demonstrated by Dr. Comenzo group in the Tufts at Boston, the rate of complete response can increase if you treat with bortezomib combinations those patients who do not get complete response after stem cell transplant. However, transplantation is a very toxic regimen in AL amyloidosis because, again, of heart involvement. And these studies by Maury Gertz showed that all cardiac transplant-related deaths are observed, again, in patients with elevated cardiac biomarkers, either NT-proBNP or troponin, all early deaths. So patients who have an NT-proBNP greater than 5,000 or a standard cardiac troponin T greater than 0.06 nanograms per mil should not be transplanted. Over time, the improvement of selection criteria improved the outcome of transplanted patients, acting primarily on the rate of early cardiac deaths. However, there was not such improvement over time in patients with heart involvement. So patients with relevant heart involvement, as assessed by biomarkers, simply should not be transplanted. This is why only 15%, approximately 15% of patients with AL amyloidosis are considered transplant eligible. This is a summary of the criteria used at our center that are pretty much the same of that used at the Mayo Clinic and at Boston University. If you decide to go for transplant should be performed with melphalan 200 because reducing the dose of melphalan does not reduce the rate of early deaths, but does reduce the efficacy of the dose. You can consider induction with bortezomib-based treatment. Mayo Clinic studies suggest that it should be done particularly in patients with more than 10% bone marrow plasma cells, as expected by hematologists. And again, in patients who were not exposed to bortezomib before, if you do not get a complete response after transplant, you should improve response with subsequent bortezomib. But unfortunately, this concerns only a minority of patients. Most patients are intermediate risk, are not transplant candidates. In 2004, we published the first paper with melphalan dexamethasone, oral melphalan dexamethasone in these patients. If we only look at intermediate risk patients, excluding patients with advanced cardiac disease, the response rate to this regimen is comparable to that of transplant, overall 76% with 30% complete response. But there is no toxicity. Also, the projected survival of patients in complete response after MDex is greater than 80% at 7 years. So this has been standard treatment at our center and in France for years. And it has been a difficult match. It has been very difficult to demonstrate that could exist some treatment better than melphalan dexamethasone in patients with AL amyloidosis who were intermediate risk. Some hope came from bortezomib. As you know, bortezomib is a proteasome inhibitor. And plasma cells need the proteasome to cope with the proteotoxicity that is caused by the same light chain, the same toxic light chain that they produce. So we postulated that plasma cell producing an amyloidogenic light chain were stressed by the production of a toxic protein, and they need more proteasome activity. And indeed, this first study that we did and we presented at amyloid meetings showed that amyloidogenic plasma cells were more sensitive to bortezomib compared to myeloma plasma cells, because they needed the proteasome to cope with the proteotoxicity exerted by their same plasma cells. And indeed, there were a couple of very encouraging reports reporting response rates up to 90% in first series of patients treated with bortezomib combined with alkylators and dexamethasone. We have recently published a paper about studying the possible role of the light chain, the amyloidogenic light chain, in inducing stress on the cells that produce this same light chain. And we used the model of this plasmacytoma that is non-secretory. We transfected these with genes from patients with AL amyloidosis and multiple myeloma. And this could be induced by exposing this plasmacytoma cells to doxycycline. And when we have these cells express the light chain, there were many deaths if the light chain was amyloidogenic, much more than with a myeloma light chain, because the light chain was toxic itself. And again, the expression of the amyloidogenic light chain made this very resistant mouse plasmacytoma model sensitive again to treatment with bortezomib. So basically, in the lab, it is true that a proteasome inhibitor is a targeted therapy for AL amyloidosis. But coming to the real life, this is what we saw. This was a study of 230 patients from our center and from the United Kingdom Amyloidosis Center. As you can see, differently from what we hope, this treatment helped most patients who were not at risk of death. And it was unable to improve the poor prognosis of stage 3B patients, those who were at higher risk of early deaths. So even this powerful combination of an alkylators, bortezomib, and dexamethasone overall has a response rate that is comparable to any other upfront treatment for AL amyloidosis in this real-world experience. And the major determinant of survival remains advanced heart involvement. We have presented last year at the ASH meeting, last December, the first phase 3 trial of novel agents in AL amyloidosis. Let me say that running this trial has been a very difficult endeavor in a rare disease, particularly when comparing an old treatment with oral melphalan dexamethasone with a new treatment with bortezomib plus melphalan dexamethasone, because everybody of us, and even patients, thought that MDex was the real answer. This was an international trial run in Europe and Australia. And these were the results, the final results of these patients. The response rate at 3 months, which was the primary endpoint of the trial, was higher and of better quality for MDex compared to melphalan dexamethasone alone. However, there was no significant difference in organ response, and there was no significant difference in survival, because patients who received frontline melphalan dexamethasone were rescued with bortezomib. So a sequential approach can be good enough. However, this was also useful because this was the first demonstration prospectively that the current criteria of hematologic response and of NT-proBNP response actually can discriminate survival in AL amyloidosis. This is how we treat patients in Pavia. This is almost 800 patients. Most common treatments are melphalan-dexamethasone, bortezomib melphalan-dexamethasone, and Cybor-D, cyclophosphamide bortezomib dex. You see that there is not striking difference in response rate. There is a slightly higher response rate for BMDex compared to both melphalan-dexamethasone and Cybor-D. However, we demonstrated this difference was due to the fact that BMDex gave a higher response rate compared to the two other regimens in patients with a high DFLC concentration. So this could be a treatment used for patients with a high clonal bulk, clonal burden. But again, there was no significant difference in survival. However, if we think now at the results that were shown by the Heidelberg group, given that patients with translocation 11-14 have poorer outcome with bortezomib, and even if I did not write this here, patients with gain 1q21 had a poorer outcome with melphalan-dexamethasone, it is possible to postulate that bortezomib melphalan-dexamethasone can be a universal treatment for AL amyloidosis, overcoming both these two adverse prognostic determinants. So our practice now is to treat with Cybor-D patients who are possible candidates for a future stem cell transplant. We treat with melphalan-dexamethasone those patients who have neuropathy and should not be exposed to bortezomib, and other patients, particularly those with a high DFLC, we treat with BMDex. But what can we do for patients with advanced disease? This 20% of patients who die in the first few months after treatment. I don't know, because there is no current treatment that can improve the outcome of these very unfortunate patients. There is nothing we can do. But if with any treatment, we get the patients survive at least 3 months, so that they can respond. If they respond, they still can have a survival advantage. As you see here, this is stage 3 patients. This is patients with very advanced heart failure. So in any case, you should try and treat these patients. And there is a lively debate now in our community on how to treat these patients. What we do in Pavia, and what is generally done worldwide, is to treat these patients with exceeding caution, with very low dose, and with a low dose escalation. Ashutosh Wechalekar from the National Amyloidosis Center in London proposes now to admit these patients to intensive care and treat them with high dose treatment. In any case, being prepared to recover them from repeated cardiac arrests. And he has some anecdotal report of very good outcome with this approach. This is why I modified this slide compared to our review last year, also to let you know that there is this debate in our community now. We have a lot of weapons to treat refractory relapsed patients. We have proteasome inhibitors, lenalidomide or pomalidomide. Pomalidomide can grant up to 70% response rate in patients who have been exposed to alkylating agents and bortezomib. Bendamustine is particularly effective in patients with IgM clones. Ixazomib is particularly effective in patients who have not yet been exposed to bortezomib. Carfilzomib is worrying because of the high rate of cardiac toxicity with this agent, and daratumumab, based on the results on multiple myeloma, is a very promising agent. I just want to show you this newly published results with our experience with pomalidomide. The response rate was 68%. You see that almost all the patients, with one exception, has some reduction of the FLC with this agent. These were all patients refractory to both bortezomib and alkylating agents. And despite this, the hematologic response to pomalidomide was 68%. Response were quick, obtained after a median of 1 month, and response, even if these very heavily pretreated patients could improve survival. So there is always a meaning in treating these patients. And this is the first effort by Dr. Gertz, again, from the Mayo Clinic, of daratumumab in 2 patients with AL amyloidosis, again, heavily pretreated, and these were very encouraging responses, you see, after a long history of treatment and of refractory disease. Sorry.
Is monotherapy with daratumumab?
Yes. Monotherapy, yeah. So there are 2 studies undergoing. One is a European phase 2 study that has just started in France, and our center will also participate in a matter of a couple of months. I have just had the first reply from the ethics committee. And then we are all designing an international phase 3 study of upfront daratumumab versus placebo in combination with bortezomib-based treatment, which could further improve our therapeutic armamentarium. This is important because this will be done with sub-Q daratumumab, which will be much less cumbersome for this.
And without any chemotherapy, like cyclophosphamide
Yeah.
and melphalan, which both could have cardiac toxicity.
Yes.
Even dexamethasone.
Yes.
Fluid increase. So
It is so.
Yes.
Everything can hurt these patients.
So
It is.
steroids and cytostatics is of profit for the patient.
Yes.
With amyloidosis.
Yes. Yes. So in any case, the follow-up should be
No toxicity.
very intensive in this in these
What's
subjects.
melphalan doses in melphalan dex?
0.22 milligrams per kilo.
How
Point-
many milligrams per day?
Between 10 and 14 milligrams, according
10
to
14 milligrams per
body
kilo. How long?
weight. We check response every 2 or 3 cycles.
And cycle lasts for 1 week?
No, cycles, it's for 4 days, every
4
28 days.
4 days?
Every
and,
28 days.
40 milligrams per day?
Yes, melphalan is 14. 14 milligrams, and dexamethasone 40 milligrams per day for 4 consecutive days. We check response every 2 months, every 2 cycles, and we go on until the patient responds. But we never go over 9 cycles for the fear of secondary myelodysplasia. Yeah. I know that the French go up to 12 cycles or even more, but we never deliver more than 9 cycles.
The most important is, of course, the dose of MDex, but the most important in amyloidosis is that the bortezomib you give 1.
Yes, 1 weekly. Yes, this is important. Yes, this is once weekly. This is a brief summary of supportive therapy. The problem is that standard cardiologic therapy is not tolerated by patients with AL amyloidosis because they have autonomic dysfunction, so they have hypotension, they do not tolerate ACE inhibitors, for example. So they need salt restriction, a very careful use of diuretics. You have to control orthostatic hypotension with midodrine or elastic stockings, and of course treatment of diarrhea and peripheral nervous system involvement. And nutritional support is also very important. What about organ transplant? Organ transplant can be considered in young patients who have isolated heart involvement. They could be transplanted and then go to stem cell transplant. Or in patients who obtain complete response, but in whom organ dysfunction is not reversible. This both for heart and for kidney. So I have tried to overview what we can do for patients now with chemotherapy. But despite all this effort and all this attention that we make, at the end, only 26% of patients will have a cardiac response and only 32% of patients will have a renal response, while 29% of patients will die in the first 6 months when we calculate response. So there is something more that we should do. And here come the other steps that we can target. And I would like to conclude with a small overview of targeting other steps in the amyloidogenic cascade. Professor Merlini, my mentor, was the first introducing a small molecule, iododoxorubicin, an anthracycline, in the treatment of amyloid deposits, because he observed that idox promoted resorption of amyloid deposits. However, this was an anthracycline, and this was a cytostatic drug, and could not be delivered indefinitely, of course. But the structure was very similar to that of doxycycline. And there are evidence, in vitro evidence, that doxycycline disrupts amyloid fibrils and reduces amyloid load. And also in our model of C. elegans, the doxycycline counteracts the proteotoxicity of amyloidogenic light chain, restoring the pharyngeal rate of our worms. And a couple of days ago has been published this very nice letter by the London group showing that this was a retrospective matched case control group. Patients who were taking doxycycline as antibiotic prophylactic along with their chemotherapy had a better survival compared to controls. They had reduction of NT-proBNP compared to controls. And in a landmark analysis, they have a higher response rate only in a landmark analysis, because even doxycycline cannot overcome the poor prognosis of patients with severe heart involvement. So we should do anything we can to keep these patients alive for some months so that they can have a chance to respond to therapy. This is unpublished. This is the first time I showed this. This is renal response rate with doxycycline together with chemotherapy in our patient population. And you see that the response rate is much higher than we expect with doxycycline. Based on this preliminary experience, I was granted by the European Union an ERAR grant to run a multi-center phase 3 trial that will involve that will be coordinated by our center and will involve Canada, the European countries in the European Union, and Turkey, to study upfront the addition of doxycycline in the prospective setting in these patients. In London, they use a different approach to get rid of the amyloid deposits. They try to remove the SAP protein, serum amyloid P component, from the amyloid deposits. This protein is a common constituent of the amyloid deposits, and it coats the fibrils. And people in London believe that this coating prevents the resorption of the amyloid deposits. So they use this palindromic molecule to get rid of the SAP that circulates in blood, and then they use an anti-SIP antibody to get rid of the antibody to get rid of the SAP in the organs. And they have these encouraging preliminary results, and we are all waiting for the study that they are going to design. Professor Solomon in the Tennessee University created an antibody that is specific for a misfolded light chain, and he demonstrated that this antibody can reduce the amyloidomas generated by injection of amyloid light chains in the mice. And there has been a study presented at the ASH meeting last year and updated this year, showing some clinical benefit from this antibody. But the anti-amyloid antibody that is more advanced in the treatment pipeline is this NEOD-001 produced by a company in California. It is important that this antibody has a twofold effect. It not only targets the deposits, but it also neutralizes the circulating precursor that we know is toxic. So this is very promising. And indeed, they have published and updated a phase 1-2 trial. This is not controlled, so we can just mention the response rate. We do not have a control arm in this study. And they found a 53% response rate, so higher than expected, looking at cardiac response in patients who did no longer need chemotherapy. And the rate of response was not related to quality of hematologic response and to time from hematologic response. So it seems that this higher than expected cardiac response is really due to the action of the antibody. The same was observed with the kidney, with a 63% kidney response rate that was not associated to the quality of hematologic response nor to the time from hematologic response. There are two controlled studies internationally underway. One is the Pronto study that has enrolled, now it is closed, we are awaiting the results. It has enrolled patients with cardiac amyloidosis and significant cardiac damage, even if they did no longer need chemotherapy. And then the VITAL study, that is an upfront treatment, an upfront study in which bortezomib-based treatment, chemotherapy, is associated with this antibody or placebo. And to conclude, I would like to emphasize the advances that we made. And now we know what we need. We need early diagnosis as early as possible. We need unequivocal typing, so we need to spread all over the European Union means to correctly type the amyloid deposits in order to avoid diagnostic and consequently treating mistakes. We need to risk adapt treatment and to tailor treatment according to response. And of course, to follow up very closely these patients in order to shift to potentially active treatments as soon as possible. And biomarkers of clonal and organ disease help us in all these steps. For the future, I see promise in combining new agents in novel, wider chemotherapy approaches, and possibly also with anti-amyloid approaches. And I just would like to mention that international collaboration is really vital in this disease. We have done all the efforts that we could to establish international collaboration. In the early 90s, we set up the Italian Society for Amyloidosis. We now have 40 centers in Italy dedicated to the treatment of this disease. In 2011, to run the BMDex versus MDex trial, we established this European cooperation that now involves Australia, and now I can say that this is surviving, this network survived the end of the trial, and now it is this same network with centers participating and centers observing, but this is the same network that will run the doxycycline study. And also Canada and Turkey have been included, and of course I would be more than happy that new dots appear in Poland. Thank you very much indeed for this opportunity.